Welcome to Omnicurus Originals. We are celebrating the Diabetes Awareness Month, and today we are having Dr. Jindal Mukta with us. Dr. Mukta is present chairman of RSSDI Himachal Pradesh chapter. He is also the professor of medicine at Indira Gandhi Medical College and Hospital in Shimla. Dr. Mukta has been honored with the prestigious Oscar E. Edward Award in the USA. And the special part is that he's the first physician from India who has been selected for this honor by the prestigious College of Physicians of America. He has been received an outstanding social award for the promotion of EDOI service in the rural area by the American Association of Clinical Endocrinology. Welcome, Dr. Mukta, for the forum is all yours to begin.
Thank you for the kind word of introduction. It's my privilege and I'm fortunate enough to interact with you all in today's webinar on diabetes. And today is management of type 2 diabetes in 2020. I will go by case presentation, and I hope in the end, who's listening me, I am hopeful everyone will be enlightened how to treat a patient in today 2020. Today we know India is housing near about 70 million diabetic population, and the most unfortunate part is by 2040 India will surpass China in housing the largest number of diabetic patients in the world. And most unfortunate part is that the 50% of the diabetic patients are not diagnosed or they are not aware about the disease. Over the last few decades, one of the largest absolute increase in the healthcare spending was for the diabetic care. This is something very unusual for me before the presentation. And mainly, we are spending it primarily on the drug. And there is the highest percentage in the last decade is near about 6.1% increase in the spending on the diabetes care. And most of this spending is primarily related to drug. Therefore, it is good to know what drugs are there and how best to use them, because to minimize the complication and to reduce the cost also. Today, the physician we have got a lot of drugs in our armamentarium to treat a drug, and we are all confused about it. Despite that, the diabetic control world over has not changed over the past 1 or 2 decades. Can we see? We have got near about 45 type of diabetic treatment option have been approved since 2005. But when we see since 2005, the diabetes control is almost, rather it has gone, if you see in 2005, and if we compare it to 2017, it has gone almost 1/3 of the diabetic population are achieving the A1C directed goal of A1C less than 7. So it is almost constant despite armamentarium or a lot of drug has come into the market. Still, the diabetic control has not improved. Based on this, I has come here. What are the causes that diabetic control is not being improved? How can we improve this outcome? Now I will start with the case scenario. Here is Mr. Vijay, who is a 60-year-old patient with newly diagnosed diabetes on routine testing with the primary care physician. He is non-hypertensive and he is on amlodipine for the hypertension. He has dyslipidemia, he is on atorvastatin for that, and he is obese. No heart disease or renal disease. Family history, mother is diabetic also, and there is a brother. Till date, he is not diabetic, and let's see what happened. And on examination, his BMI is 34. He has worked on his diet and start exercising and diet control, and his latest A1C is 8 with fasting blood glucose is under 80. So now, this is the scenario we see in day-to-day clinical practice. And most of the time, we see this scenario. Now, how best we should treat this patient? Let's go first. My first question to the viewer is, what is the first agent? And everybody will be, what this easy question is. Everybody question here is, I agree on this point. Metformin is the first choice. The question, why metformin? Why not sitagliptin? Why not canagliflozin? Why not glipizide? And why not pioglitazone? This is the answer we have to give being a scientific doctor. So when we see the omnious octet of the diabetic, metformin acts on only one of the 8 core defects in the pathophysiology. That is, the metformin acts only in the liver and it reduces the hepatic glucose production from the liver. I say, to be very scientific, it does have very, very little effect in the periphery as a insulin sensitizer. So main effect of the metformin is on the liver, and out of the 8 defects, it acts only on liver. Still, it is the first drug everybody will say metformin is the first drug. The question is why? The answer for that is it is a very potent drug. It reduces the A1C It is one of the most potent drug by 1 to 2%. Excellent. It has got higher initial rate. If you put the patient on metformin, there's about near about 90% patient will respond initially. And it is available in the nook and corner of world over, not only in India, world over, low cost. It has got weight neutrality. Rather, there's a modest weight loss. Rather, I have seen in my clinical practice, metformin does lead to weight loss. And it has got some advantageous effect on the lipid effect also. And the most importantly, it decreases the macrovascular complication. And to prove it, whether it really reduces the macrovascular complication, I'm going to take you people to this cartoon of UKPD study. The UKPD study is the study that is an observational study, no doubt, the longest interval, 10 years follow-up in the study, and 10 years post-study follow-up was done in this study. When we see this conventional treatment, that is diet and exercise, and this is on your sulfonylurea, this is on metformin. When we see there is near about 40% reduction in myocardial infarction as compared to conventional and as compared to your sulfonylurea group in metformin group. So metformin is associated with the reduction in your cardiovascular, particularly in the non-fatal myocardial infarction. And not only during the period of your study, and the reduction persisted 10 years post follow-up also. The study was finished in 1998. UKPD, the patient was followed up for next 10 years up to 2008. And the paper was published probably in NAJM, where it was saying the beneficial effect of the metformin persisted for next 10 years, and there is statistically significant reduction in the occurrence of the myocardial infarction in this patient who were treated with the metformin. So this is the evidence it is a cardiovascular effective medicine. So having said all that, we put together all the recommendations, be it be EST, be it be American Association of Family Physician, be it be American College of Physician, Diabetic Association, American Association of Clinical Endocrinology, International Diabetic Federation, everybody guideline are in agreement. Metformin being efficacious, it is safe, tolerability, less hypoglycemia, and weight loss. With extensive clinical experience, every guideline recommend metformin as the first treatment in the management of the diabetes. That is, it is the clinical evidence we have got. Now, when we see in clinical scenario, a study was done and published in 2017 by Monvitada in diabetes care. The first drug, even in USA today, the first drug, near 80% of the diabetic patient, the first drug is chosen as metformin. So it is not only the guidelines, it is not only proof of the science that it is a good drug, but even in clinical practice, even in adult like USA, the first drug in near about 80% is metformin. That is the thing. And so there's no doubt the metformin is the real world scenario is in fear of that. So having said that, it is the most important drug and we should not lose this drug. When I talk to my resident on the ground, I say it is illegal. It is not, I think, the patient, no contraindication, any diabetic patient should not be without metformin. This is my statement when I go on the ground until it is contraindicated. So patient is going to take this drug and we should encourage that it should be continued and it has to be taken by the patient lifelong. We should know a little bit about how to start. So sometimes we are in hurry in our OPD and we start the patient with 1 gram and there is a GIT intolerability and patients start refusing such a good cost-effective drug. So we start always with the meal. And start always with a minimum dose of 500 milligram with the evening. Then after some time with the 500 milligram with the morning with the breakfast, then increase to 1 gram and then maximum of 2 grams. So initiates it a lower dose, initiated the single dose, and slowly within 3 and 4 weeks increases to maximum, and maximum dose is 2 grams. So it is not used. Metformin should not be used when EGFR is less than 30. That is the practical utility of the metformin. So Vijay was treated by me, the metformin initially 500 BD, then 1 gram, and he A1C after 3 months was 7%. Excellent. And the ADA recommended goal. And after 12 months, he came back and his A1C was 7.2, just increased, and he started increasing his exercise from your half an hour to 45 minutes. But unfortunately, when he came back after 2 years, his A1C was 8% here. And that is the usual scenario we see in day-to-day clinical practice. Okay. So now your 2 questions need to be answered by the clinician who is active in treating the diabetic patient. Is the initial reduction of A1C in the patient, or why the A1C start rising after 1 year, or when it start initially when it fall, but why it start increasing? So to answer the first question, I will take you back to your UKPD study where it has been elegantly shown 1% reduction in A1C leads to 21% reduction in diabetes-related deaths That's very important. 37% reduction in microvascular complication and 14% reduction in the myocardial infarction. This is the most important slide. I have just 1% reduction due to all this benefit to my diabetic patient. And the most important is that this 1% reduction is very important in the first year of the treatment after diagnosis. When we see this elegant study, and we divide the patient into with the diabetic patient newly diagnosed with history of cardiovascular disease and no history of cardiovascular disease and history of the cardiovascular disease. When we see if the A1C remain more than 7% at the end of the 1 year, there is an odd ratio of increased cardiovascular event of myocardial infarction, stroke, and heart failure by 1.64. Odd ratio of increasing of your cardiac event when A1C is more than 7% at the end of the 1 year. So having said that, the most, and if patient has cardiovascular disease, it is increased to near about 1.67. So this A1C reduction is most important in the first year after the diagnosis. Otherwise, the patient will have 64% increased risk of cardiac event if our patient has got A1C more than 7. Second important question is why? What is the disadvantage? UKPDS again give us this answer here again. The patient is on conventional therapy, is on glibenclamide 1 hour. Second arm is on metformin C. When the patient accept for your conventional, the patient on sulfonylurea and metformin, there is initial rapid fall in A1C, and we are very happy. And this is up to it remained for 1 year as seen in Mr. Vijay here also. After 1 year, the A1C start increasing whether the patient is on metformin or on your glibenclamide. And can you see this cartoon here again? At the end of the 3 year in metformin arm, only 44% maintained A1C of less than 7. And after 9 years, only 13% of the patient was maintaining what you call ADA recommended goal of less than 7. And when we go for the glibenclamide sulfonylurea, at the end of 3 years, near 50% of the patient were maintaining A1C less than 7. And at the end of the 9 years, only 1/4 of the patient was maintaining 24 hours. And when we go back to the 15 year, near about the A1C was 8% after the 15 year, despite the patient was on metformin, sulfonylurea, and 65% of the patient was on insulin. This is what is happens in day-to-day clinical. We see in our day-to-day clinical. So there is a deterioration in the A1C as the disease progress. So this is nothing to do. I will put it in a natural history. This is a slide I love to have. And we have to understand by the time we diagnose the diabetes, near about 50% of beta cell is lost, both morphologically and functionally. Beta cell, 50% beta cell is lost. So there's a natural progression of the, with the passage of time, there is a progressive failure of the beta cell because of the apoptosis. It is not the failure of the drug. It is a natural progression of the beta cell failure that we encounter, and we should not blame the drug. So it is the natural history of the disease that is to be blamed rather than the drug. So natural history, we have to stop this natural history, and let's go ahead how we can do that. So second important is why the drug or sulfonylurea, when we put the patient on, this is for me is the most important, pathophysiologically the most important cause when we start the patient on single drug is that when we put the patient on metformin or sulfonylurea, we correct only 1 out of the 8 core defect of the diabetes. Like if we treat Mr. Vijay with metformin, I am covering only 1 core defect, that is hepatic glucose production. I'm covering. I'm not increasing insulin. I'm not decreasing glucagon. I'm not reducing his glucose filter in the kidney. All that I'm not, but only 1 defect I am. That's why with that period of time, the 1 drug failed. This is most important. Now, second question is, what should the next drug of choice in Mr. Vijay here? Should it be DPP? Should it be SGLT? Or should it be sulfonylurea? Should it be pioglitazone? Or should it be what you call GLP-1 receptor? This is the answer we have to give because his A1C is 8. Now, when we have to choose the drug, we have got a lot of drug today, and that is where the clinician is confused today. We have got a lot of medicine here. Near about 12 to 15 drugs available. And here, sometime when we are sitting in OPD, we think for the while, which I should add to the patient. Okay. Now let's see what is the best drug that we choose according to patient characteristic. Let's go for that. Now, till date, when I was in medical school, the efficacy of the drug was the sole criteria for choosing an anti-diabetic drug. Sole criteria. That's the sole criteria. We have to achieve what you call A1C less than 7. That is, I think maximum is, we are thinking we have to chase the A1C to less than 7. That is also criteria of management of type 2 diabetes. Efficacy, lowering of the A1C. That's good thing. Back to Mr. Vijay. So Mr. Vijay is the same. He is hypertensive. He is a newly diagnosed diabetic. He is on amlodipine and atorvastatin. And the most important characteristic here is BMI 34. He never reported any hypoglycemia. He does not have a kidney or heart disease. But here, the characteristic of the patient is that what I'm seeing, the characteristic most important here is he is morbid obese. So this I have to consider in my patient. Because so when we go by the ADA-ESC recommendation, if somebody, the compelling indication is to minimize the weight and to promote the weight loss, what the ADA-ESC guidelines tell us, the GLP is the first drug we should choose. If not GLP, then SGLT2 the drug we should choose. So when we have the compelling indication of reducing the weight, the ESCT guidelines is very clear about it, that when we have to say we have to reduce the weight, GLP-1, if not then SGLT2, if not then DPP inhibitor. So in that sequence we have to go. So naturally, my patient has got the compelling indication of reducing the weight because he is a less chance of developing, he does not have renal disease, he does not have comorbid. So the GLP, we all know GLP is nothing, but they are the GLP and GIP is glucagon-like peptide and gastric empty inhibitory polypeptides. These are the polypeptides. They are secreted by the terminal ileum when we eat something. And these GLP and GIP, they cause increase. Now, near about, let me tell to my viewer, that 60% of insulin from the pancreas is reduced in response to incretins, the GLP and GIP, 60%. And it causes insulin secretion, it causes proportionate decrease in the glucagon, it reduced the gastric emptying, and it increased the satiety also, reduced the appetite. So these enzyme unfortunately is deactivated by your dipeptidase peptidase 4 inhibitor immediately. So how can we increase? Either we can give the GLP from outside or we give it DPP4 inhibitor. GLP given from the outside are more potent because higher concentration is given from the outside. Okay? So, and second, pathophysiologically, when we give GLP or DPP inhibitor, it almost all, except for your glycosuria from the increased glucose excretion, it address all the core defect of the diabetes. It increased the insulin secretion, it reduced the glucagon, it increased the satiety, reduced the appetite, it preserved the beta cell. There is some evidence it increases the sensitivity also. So almost all the core defect of diabetes when we give the GLP from outside. And they are efficacious. Near about, it has been shown in different trials, the GLP-1 given from outside reduced the A1C from 1 to 1.6% and associated with 2 to 3 kilogram of the weight loss. And this is much required in my patient. So the GLP-1 receptor, when given to the patient, effectively reducing the A1C, it preserves the beta cell, promote the weight loss, correct the pathophysiology. Drug is either sulfonylurea or thiazolidinediones. So that's a choice. We remain with Mr. Vijay here. So let's go back. So what is the advantage of the sulfonylurea? So the advantage of the sulfonylurea is it is a very potent drug. Again, like metformin, it is one of the most potent drug. It reduced the A1C by 1 to 2%. It has got very high initial response. In a study, it has been shown 70 to 80% of the patient respond to, and there is a 20 to 30 of primary sulfonylurea failure. The most important is it is among the OHA which act very promptly in reducing the blood sugar. You give the patient sulfonylurea, ask him to come after 1 week, the glucose is reduced markedly. So it has no lag time prior to response. It acts very immediately. This is the best response. If you want to reduce the blood sugar very promptly, this is the one of the oral drug that we should choose. It is low cost, once daily, and mostly we can combine with any of the armamentarium we have got in treating. We can be combined metformin, alpha glucose inhibitor, DPP, can be combined with any drug. Okay, so but there is a concern here. We have got a hypoglycemic concern. When you go to any conferences, we see a lot of talk on the hypoglycemia. Let me clear it clearly to my audience. This is exaggerated fact. So hypoglycemia is the most feared concern in sulfonylurea, but it is not so common. Why? But this is not this half statement, especially in those patients who are normal weight with normal renal and hepatic function and who are eating well. It is quite rare. It's 3 conditions. But it is important risk factor when we skip meal, when patient has a kidney or hepatic dysfunction, or in elderly, hypoglycemia is a concern. Except for elderly with hepatic and renal dysfunction and with the erratic meal habits, hypoglycemia in day-to-day treatment is not commonly as it's been described in the literature. Sorry, second. Yes, it does cause the weight gain. We have concern, but only the maximum weight gain has been implicated to the level of 0.52 kilo with the sulfonylurea in any of the studies. The highest is, as you mentioned, to be 2 kilogram only. Okay, so next is the cardiovascular safety concern. This is a very important concern. So I'm going to take you with 115 trials that has been done more than 6 months. These meta-analysis has found no consistent association with increased MACE with your sulfonylurea. This is very important. MACE means major adverse cardiovascular outcome. And these were the randomized trial, not your, these were the observation studies. They say the CV safety of the sulfonylurea can't be considered established unless we evaluate it in a long-term cardiovascular outcome study. Still, these 15 meta-analysis, 115 trial has shown it does not increase the MACE. But I'm going to take you people for the Carolina trial. We all know, published in 2019, 18 in your NAGM, 6,000 patients, and the study was carried for 5 years. It was a randomized control trial between your sulfonylurea and your DPP inhibitor linagliptin. What it's shown, the 2019 ADSA, no difference in cardiovascular outcome. It has been shown that like your DPP inhibitor, the sulfonylurea is neutral in the cardiovascular outcome. And most important, in 2020 EST, 23rd September, about the Carolina trial, 15% for age more than 75%, no difference in outcome. So even relatively safe in older patient also. So the Carolina trial put rest to all the speculation of the adverse cardiovascular outcome with sulfonylurea and say it is neutral. At least it is safe. So we should consider particular glimepiride and gliclazide to be cardiovascular safe and can be used with confidence. This is the statement, in confidence in the effectiveness for reduction of the microvascular complication as well as your cardiovascular safety. So as far as this cardiovascular after Carolina is put into, it does not increase the MACE in diabetic patient. And when we see what is the second agent in the real world scenario, sulfonylureas are good, they are efficacious, acts very fast and cheap. Our patient selection is important. Be careful in patient with kidney fatigue dysfunction in elderly and patient with pediatric male, and it is the second most oral anti-diabetic agent. Even near 50%, the second agent added in USA are sulfonylurea. Okay, so this is a good choice. So after discussion with Mr. Vijay, he agreed for the sulfonylurea treatment and was prescribed 1 milligram and 2 grams of metformin. Unfortunately, he returned after 4 weeks with 2 mild episodes of hypoglycemia. May not proven, but mild episode, but unable to lose weight. Rather, when we saw there was a 0.5 kg increase in the weight, despite he was adopting a healthy lifestyle, he already had increased in physical activity and reduced caloric intake, so he was not so happy with this drug. So second is thiazolidinediones. For me, it is a very good drug, but practical point in this patient, because of your weight gain, slow onset of the action, edema, heart failure, all these can't be used so well in our patient, which is under discussion here. So I will not recommend thiazolidinediones to be a good drug in Mr. Vijay. So when we see this in a real world for the second agent, in 2005, this thiazolidinediones was a good drug to be prescribed even in USA. It has, in 2005, near about 30% of the person was on pioglitazone, but today it has reduced to 4% only. And the main reason is weight gain and heart failure contraindication. So because of this, the thiazolidinediones has come down, and this is not a good drug that we can use in our patient. So to conclude with the primary drug we have today, we compare the metformin, sulfonylurea, pioglitazone. All are effective, reduce the A1C to the same level, work equally, but all fail with the passage of time. This is elegantly shown in UKPDS, the drawbacks. So here going back to Mr. Vijay, so being overweight, being hypoglycemia, sulfonylurea thiazide was not a good choice in Mr. Vijay, and his BMI was 31, for which he was most concerned. So question arises, what the next we should choose in Mr. Vijay. So dear colleagues, today when we move from in diabetes treatment to 2015 and 16 and 14, after a core trial, it has become very clear that we have to move from efficacy in lowering the A1C to the safety in preventing the hypoglycemia and weight gain. Today, the main emphasis after that trial, a core trial, was safety and weight gain. The two important factors in deciding the second drug is safety and the drug which will not increase the weight, because most of the diabetic patients are overweight or obese rather than efficacy. So if we go by the ADA guidelines, again, if we have to compelling indication for hypoglycemia is there, we have two drugs. First is the DPP, and second GLP, and third is SGLT2 by 2020 EST guidelines. GLP-1 patient refused. SGLT2 inhibitor, we do not have any data. The person do not have a data where we do not have any cardiovascular established disease or kidney disease. So the first drug they choose is DPP-4 inhibitor. So DPP inhibitor, I told you, the GLP-1 immediately when we take something orally, the GLP and GIP secreted is immediately deactivated by DPP enzyme. When we with this enzyme, these GLP and GIP concentration increased by 3-fold in our body. And this DPP-4 enzyme and these are reduced in patient who is diabetic. There's what you call DPP enzymes are deactivated, or they are down regulated in diabetic patients. So we have to upregulate these enzymes, and we have to give something from outside that prevent the degradation and that increase the concentration of GLP and GIP in our body. So they are very efficacious. They are modestly efficacious. They are not very efficacious. Near about 0.8% in reduction in A1C, whether it is given as a monotherapy or it is combined with some other therapy. It is modest. I call it as it is equal. They all are equally effective. Doesn't matter which one is used, and it is of the modest efficacies. It is of the modest efficacies. And second important is, though modest efficacies, it pathophysiologically, like GLP, it covers the multiple core defect of the diabetic pathophysiology. That is the most important form. Multiple core defect of that. It increase the insulin, it reduce the glucagon, it increase the satiety, and it reduce the gastric emptying. So it has got multiple core defect correction in treating the diabetes. When we go for the cardiovascular safety, it is neutral. Here trial, Examine trial, TICOS and Carbamazepine, we have seen, and Savior TIMI trial, we have seen they are neutral. Though they are not beneficial, but it is safe when we use these drug to a patient who has got established vascular beneficial effect, but it does not have negative effect. So they are cardiovascular neutral. That we can be used safely in a person and who has got established cardiovascular disease. So it is weight neutral, it is favorable. For me, they have modest efficacy, but in my clinical experience of 15 to 20 years, I have found to be the safest one. When I prescribe DPP inhibitor, not even single patient come back with some side effect in my clinical experience. And in USA, this is called weekend pills also. Weekend pill, because most of the doctors, they go on the recreation at the end of the day, they prescribe this and patient does not call them back, does not have any complaints. So there I consider, and my personal experience and literature do support, it is one of the safest. It's the safest anti-diabetic drug can be used, though modest efficacy. As a second agent, when we go by the literature, this is the published in 2017 again, these are after sulfonylurea. It has come up from year 2006. It has increased in prescribing in USA after sulfonylurea as a second drug. Though in 46 sulfonylurea is prescribed, but now near about 20 to 25% of the patient, the second drug has shifted towards. So based on the latest evidence, Mr. Vijay was treated with DPP inhibitor and metformin, and he returned back after 3 months with A1C of 6.7 with 1 kg weight loss and no episode of the hypoglycemia, and he was happy. And ultimate aim of the doctor is to improve the quality of the life. So this is up to the how we should treat a patient who does not have any. Now I'm going to take you people with the latest evidence. He's a twin brother of Mr. Vijay. He came to me, and his age is he's a twin brother, so his age is 60, and he's a newly diagnosed diabetes on admission to the hospital for MI. He presented with MI, and during his hospital stay, he was diagnosed to be newly diagnosed diabetic, and his history of hypertension, dyslipidemia, and he's obese. His past history is coronary artery disease with ejection fraction 35, CKD stage 2, EGFR 50. He's a diagnosed MI, so he's ejection fraction 35, and he's a CKD patient. And he's on amlodipine till before his admission, and his BMI 34. A1C is 8. How we do discharge? What is the best medication to treat and discharge the patient, Mr. Vijay's twin brothers, when patient presented with all these complaints to us? This is the second case I will going to discuss now. So now, the first question here is the twins brother of Mr. Vijay, he has coronary artery disease, he has got stable heart failure, he has got diabetic kidney disease, still we use the metformin not. This is the most commonly asked question, and we have to reply. Okay, now what is this? So as per the UKPD's concern, we have seen it in previously also, metformin is a cardiovascular safe drug. There's a reduction in 40% in myocardial infarction when we treat the patient. So as far as cardiovascular is concerned, it is a safe drug. Rather, it is a cardiovascular, it's not only safe, Rather, it prevents the cardiovascular disease. Second concern with our patient is that he has got EGFR 50. Now, guidelines recommendation is that we can safely use metformin up to 45. We can safely use the full dose up to 2 grams. As soon as the EGFR falls from 45 to 30, use the half the dose of metformin. It should not be used less than 30 of the guidelines. Though the latest evidence is coming up, even it has been shown to reduce the cardiovascular mortality in patient with EGFR up to 15. But I will tell guidelines. So any person whose EGFR is above 45, the full dose of metformin can be easily used. And if the EGFR is between 45 to 30, half the dose, that means up to 1 gram can be used. And our patient, Mr. Vijay's twin brother, has 50, so I can safely use up to 1 gram or 1.5 gram of the metformin. And his heart failure is stable, so it is not a contraindication to use the metformin. So this is the drug I will love to use in Mr. Vijay's brother. So second question here is which second anti-diabetic drug should be added to metformin to Mr. Vijay's twin brother, that's who has got established coronary artery disease, heart failure, diabetic kidney disease, and what should be the glycemic target to Mr. Vijay's brother? So to answer the first question, I'm going to take back my audience to the ACE 2020 guidelines. This is the best thing. Independent of the glycemic control, patient has got A1C 12 or even the patient has got A1C of 6 on drugs, independent of the glycemic control, if established atherosclerotic cardiovascular disease or high risk, I will define the high risk. If the age is more than 55 and the stenosis is more than 50% and there is a diastolic dysfunction, this is high risk. And patient has got diabetic kidney disease or diabetic kidney disease in stage 3, heart failure with reduced ejection fraction. If this condition is there in our patient, then start either with your long-acting GLP-1 receptor or SGLT2. Very important, these two drugs, independent of the glycemic control. Forget about the glycemic control. Let it be 10, let it be 7. We have to treat with these two drugs. That is the ACE guideline 2020. And what does AD and EST guidelines? Again, the same, independent of your A1C target. If we have got they divide into two. If you have got a predominantly atherosclerotic cardiovascular disease, that means myocardial infarction, stroke, or peripheral vascular disease, and who has got high risk means age more than 55 with coronary, carotid, and lower artery stenosis more than 50% or left ventricular hypertrophy. These are the high risk patients. First preference is GLP-1 receptor, not your SGLT. It is not the SGLT, it is the GLP-2 receptor antagonist. And if patient has got heart failure and CKD, that means the first preference is SGLT2. This we have to keep in mind. Mind it. The first preference here is atherosclerotic cardiovascular disease is GLP, and for the heart failure, it is SGLT2. If we have to add, we have to complement with each other. If you are using GLP, they need another treatment. SGLT2 is the treatment of choice here. And here, if you are putting the patient on SGLT2 inhibitor, they need further exertion. GLP-1 receptor is the antagonist. But if patient is not taking or not is contraindicated to one of these drugs, the next choice is DPP-4 inhibitor. This is given below here also. So if patient has got atherosclerotic cardiovascular disease, the GLP is the first. If heart failure, CKD, SGLT2. So why question arises, medical doctor, why GLP? We know the 3 trial, LEADER trial, and we know your SUSTAIN trial. These 2 trials with liraglutide and semaglutide has been consistently shown significant reduction in 3-point MACE as far as cardiovascular outcome trial is concerned. Statistically significant reduction in non-fatal MI, non-fatal stroke, and cardiovascular death. But as far as kidney is concerned, it has got only biochemical change, and it has not seen, except for reduction in macroalbuminuria, and in heart failure, no consistent, so much reduction is not, but it was in favor of your consistently reducing cardiovascular 3-point MACE in these 2 trials. Based on these 2 trials, they are considered to the primary drug for atherosclerotic cardiovascular disease. Now, question arises, SGLT2. Now, we know the 3 cardiovascular outcome trials with SGLT2 DAPA. What you know, EMPA trial, CANVAS program, and DECLARE DB-TRAM. This is for your EMPA trial. This is empagliflozin, canagliflozin, and dapagliflozin. When we see these patients initially for the large cardiovascular outcome trial, mind it, the 3-point MACE, cardiovascular death, and heart failure. When we see the 3-point MACE is only reduced by EMPA and CANVAS, but cardiovascular death is only reduced by EMPA, but not by CANA and DECLARE. Based on this, they are recommended as a second drug for the patient who is predominantly atherosclerotic cardiovascular or established cardiovascular. But as far as heart failure is concerned, we go across all the trial. There is highly significant reduction in the occurrence and in the prevention of the heart failure. That's why the heart failure patient has been shown to the primary drug as SGLT2s. So my view, this is the reason why the GLP is considered first in established drug. So now we go for the kidney. Why the kidney SGLT2 is considered? We know the two trial. I'm going to take my audience with the two trial. Credence trial is the first, and this kidney, what you call the renal dedicated trial of this canagliflozin in diabetic patient with renal disease. But here the characteristic of the patient is that it was a highly risk patient here. They fall in this category because eGFR was 56, and in our patient Mr. Vijay's twin brother it was 50. So this was the trial done in G3 patient with the proteinuria more than 3 grams. So they are called high risk patient. So one. Second is your DAPA renal trial. In DAPA renal trial, it is both diabetic and non-diabetic patient. Furthermore, high risk patient, even here the eGFR for 43. So high risk patient of what you call kidney disease was taken in these two trials, and they were, one was with the CANA, another was with the DAPA. And when we see the characteristic here, this is eye-opening for me at least. Not only with respect to your biochemical abnormality, that is doubling of the serum creatinine or reduction in the eGFR. For me, if a doctor is treating a patient who has got renal disease, my personal aim is to delay the dialysis, to delay the transplant, and to delay the renal death. I will not care for what is the creatinine of the patient. My ultimate aim is delaying the dialysis, or delaying the transplant, or preventing the renal death. All three was statistically, it is going line of the unity, it is going towards the right side. So statistically, there was a reduction in patient going for dialysis, kidney transplant, and renal death with these two drugs. So this is highly significant for me. So now second question is, that's why these after Credence and DAPA trial, after heart failure, the renal patient always the first preference is not GLP, but rather it is SGLT2. Based on these, in heart failure and in renal patient, the first choice based on this trial, we have scientific evidence SGLT2 the first drug until unless it's contraindicated. So as far as this, how much should be the A1C of my patient, Mr. Vijay's twin brothers? So it should be near about 7. I put this individualization of therapy. My patient is a newly diagnosed. He does not have so much of comorbidity. It's just 50 of the eGFR. So here, when patient is on in stage G3A, my concern is to prevent the progression of his renal disease and to prevent microvascular complication. And in preventing the microvascular complication, A1C is the best marker, the control of the A1C is the best marker to reduction in the progression of the microvascular disease. And my patient does not have very high risk of hypoglycemia. He does not have so much comorbid. He is obese. So I will try to not 6.5, but I will try to maintain A1C in Mr. Vijay's twin brother to near about 7, of course. And the drug, I will try to use that will cause the least hypoglycemia to Mr. Vijay's brother. That is my concern. So my concern here is 7, near about 7, not less than 7, not more than 7, because not less than 7, chance of hyperglycemia, more than 7, progression to renal disease. So I will go a balance. I will try to keep the A1C2 near about 7. So based on this GLP receptor agonist and GLT2 inhibitors trial, inhibitor is a good add-on to Mr. Vijay twin brother on metformin. My personal preference is in favor of GLT2 inhibitor, as prevention of renal progression of heart failure is my priority, in addition to preventing the recurrence of coronary event as a complication of the diabetes. However, the renal impairment, this is very important to say. Moreover, the renal impairment, eGFR 50, with your proteinuria, multiply the risk of the coronary event by factor 50. Moreover, GLP is injectable, it is high cost, and I will try to keep the patient's A1C to 7. This is how will I treat the patient. So I treat the patient, and I've got good evidence for even for your coronary event with your empagliflozin also, that reduced not only MACE, but also cardiovascular death also. So this equalize me with that of your GLP. So here my patient has gone, in addition to that, I want to prevent the consistent heart failure reduction, and kidney reduction is not so good with GLP. So in combined together, I will favor more a SGLT2 inhibitor rather than a GLP receptor agonist. So what is the new treatment diabetes or diabetes 2020? Now let's go to the third portion of the talk. So my dear friend, this is the document of 2020 that came out in January. I will advise everyone, please go to this document. This is excellent written document and covers almost everything as far diabetes is concerned. It is a very small document. So the first thing when I read this document, first I go to the center of this document. That's goal of the care. The goal of the diabetic care is to prevention the complication. It's not the A1C. And It is improving the quality of the life. Let me tell to my audience first here, this should be the goal of treatment of diabetes. Preventing the complications, the primary goal, and secondary is your improving the quality of the life. My patient's quality of life improve after I put the patient in diabetes. And second patient, I choose the drug that reduce the complication. So here the first characteristic when patient comes to our OPD in day to day is to see the patient's characteristics. The most important is to see the patient's characteristic and what the AD and EST says us about this patient's characteristic. So dear colleague, the shift of the after our SGLT2 in vitro trial and after leader trial is it has shifted initially from efficacy. Choice of the second drug initially shifted from efficacy in loading A1C to safety, prevention hypoglycemia weight gain. Now the whole emphasis is prevention cardiovascular and renal protection. The two things we have to think of. This is the latest 2019 guidelines. Any patient is coming to us, first rule out the cardiovascular renal protection. So the first characteristic when patient comes to us in our OPD is that assess for the cardiovascular renal disease. Two things. Assess for the atherosclerotic cardiovascular disease or heart failure or CKD patient. If patient has these or not. That's the first thing if any patient is coming to us. This is the first thing a clinician should do. This is the first characteristic of the patient we should try by history or by the investigation. If they are present, always prescribe independent of your A1C level, either GLP-1 or SGLT, depending upon if atherosclerotic cardiovascular dominance, prescribe GLP-1. If heart failure, kidney disease, prescribe SGLT2 in addition to metformin. That is the first message I want to give to my audience today. First thing is that if your patient does not improve, add the complement. When patient you put on GLP, require resistant therapy, put the patient on SGLT2. If patient is on SGLT2, not requiring GLP. If not even this injectable is not, then DPP is the choice. That is clear from your EST guidelines. And that too is complemented by your ACE2 guideline. In established patient with atherosclerotic cardiovascular disease, in CKD and your heart failure, the GLP and SGLT2 are the initial drug which you choose. There's no question. So when patient is coming to us, first assess for cardiovascular disease, renal failure or renal disease. If they are the two drug, GLP and SGLT, not a big issue here. So now why it is important? We know in India, today we are facing near about 9% of adult population with diabetes, 70 million. It is going to be highest in 2040, 20 years after today's talk. So now near about when we see the patient in day to day, 32% of the type 2 diabetics have coronary disease. Near about 12 to 45% has type 2 diabetes has heart failure. This is underdiagnosed, very important. And near about 60%, near about half of the patient with diabetes has CKD. See that this is the volume of these patients. And when we have got 60% of patient with heart failure and type 2 diabetes has CKD, and 34 to 45% of heart failure have CKD. So these are very intermingling with each other. That's why it is very important to know the first rule out the coronary atherosclerotic cardiovascular disease, kidney disease, and heart failure in your patient. So once that is ruled out, if we do not have this, the question here is, yes, treat with this drug. If no, then see the other characteristic of the patient after metformin. What characteristic we have to see? Need for minimizing hypoglycemia to minimize the weight gain and promote the weight loss. Once this consideration is ruled out, patient does not have atherosclerotic cardiovascular disease, and these we see in daily to clinical practices near about 20 to 25% of the patient. Rest near about 70% does not have all these established cardiovascular disease. Then what we have to see? We have to see the other characteristic of the patient. What is? We have to minimize the hypoglycemia and we have to minimize the weight gain. So based on your AD-AST guidelines, if we have got patient who has a compelling indication of hypoglycemia, like I give you example, patient who has got elderly patient who has got erratic meal, so DPP is the first choice. When we have got compelling indication of weight loss, GLP is the when cost, then sulfonylurea. So based on these three characteristics, we have to devise the second agent to our patient. The second characteristic. So far we have discussed which second oral agent should be added to metformin, and we are convinced that what we should we add. How the best and most important question need to answer here is, after initiation of lifestyle change in metformin, how long we should wait to add a second drug? This is the most neglected question when we go we seek to most neglected. How much time we should wait in adding the second agent? That is the most pertinent question in my opinion. So what does the AC 2018 clearly say? After you put the patient or initiate with any of these drugs, whether it's metformin, whether it is SGLT, DPP, always just not go beyond 3 months. If A1C is not controlled within 3 months, please add the second drug. If after adding the second drugs and wait again for the 3 months, then add the third. So here the point of concern is you take one message today, 3 months only. 3. If you put the patient on single drug, patient is not improving 3 months, please add the second drug. This is the most important, what is the most neglected questions that is not being answered. The practice we are not doing in clinical practice day to day. However, it is seldom seen in clinical practice. And there is the inadvertent delay in intensification of therapy. This is the elegant, I love this trial very, very much. You know, when we add the second drug to the first drug, there's a delay of near about 1.6 to 2.9, near about 2 years delay in adding the second agent. But most importantly, when we go from second to third agent, there is a delay of near about 7 years. When we add the third agent, there is a delay of another 7 in initiating the insulin. So this is the biggest, that's why I say this is the most neglected question that is being answered in any of form. And what happened? The patient A1C remain always elevated. The ADA recommend less than 7, the A1C remain always elevated because we are not adding and what we called as a therapeutic inertia. This is the way the delay in initiation or intensification of the therapy when it is required is what is called therapeutic inertia. So there is an inadvertently delay for years together, for decades together in intensification. And what is the reason? And when we delay, there is an excessive glycemic burden the patient is under. Excessive patient, the A1C remains very, very high. So the biggest disadvantage of sequential add-on therapy is failure to treat. So patient remain in hypoglycemia for the years together, for the decades together, for years together. And what is the consequences? The elegant study is shown here. When the patient is delay in the intensification of the A1C remain elevated and patient in excessive glycemic, it drives the complication. What is the complication? We say when A1C more than 7, after 5 years, there is a 67% increase in myocardial infarction, 51% increase in stroke, and 61% increase heart failure, and complication of cardiovascular near about 62%. So when we treat the patient, we are putting the patient on excessive and we are doing nothing but we are driving the complication to the patient. And this is to the tune of more than 60% within 5 years when we do not add on or we do not intensify and we do not bring the A1 to less than 7. That's the biggest thing that this slide I love it the most. So delay in intensification leads to nothing but complication. Okay, so in general, A1C worldwide have not changed much despite a lot of advance, particularly in the field of pharmacotherapy, which speak to the importance of education. Be proactive and avoid therapeutic inertia, and also making sure that regimen for the patients they can afford and they can. And because of this inertia, the A1C from 2005 to 17 has not changed from 31 to 31%. The therapeutic inertia is one of the reason for this. So what has that ADA guideline 2020 has come up? Once at the time of the diagnosis, the A1C is above than 1.5%. They say there's a data to support initial combination therapy. Hit hard, hit the beginning. And this has come out with the ADA standard of guideline 2020. If A1C 1.8 means if a patient is coming with A1C or more than 8.5, our aim is 7. If patient is coming with more than 8.5, at the time of the diagnosis, give the combination therapy. And I love to have a what you call fixed dose combination. Any of the fixed dose combination, the characteristic I have elaborated in the beginning. And is it supported by some other? Yes, it is supported right from 2018, not today, 2018. It is supported by ACE guidelines. If the A1C is more than 7.5, they say even they are the ADA is more liberal, they are more strict here. They say if A1C is more than 7.5 and between 9, always in the beginning, choose your metformin plus agents. Always use double therapy, combination dual therapy. Always take. This is the why it has been. There's a verified trial that was published in Lancet, where the patient was treated with vildagliptin and metformin at the time of the diagnosis, and they were followed up for 5 years. Can you see? There's a statistical significant difference in the A1C, and it remained for the long period, and there's a reduction in the complication. So, my dear colleagues, move from what we call as an proactive approach in treating the patient. So when you treat the patient, this is the initial, you use the one drug, When it fail, you add another drug. When it fail, so I call it is a paradigm of failure. Treatment, this what you call algorithm of the failure, treatment for failure. When we fail, when we add something. So I called it is a paradigm of the failure. So when we initiate, combine the double drug here, we bring down the A1C to the desired level and it remains there for prolonged. So be proactive and try to give the combo at the time of the diagnosis. And what my personal trial in IGMC, I did a trial and it was followed up to 30 months. This is on 24 months, but it was later on followed up to 30 months. I put the patient at the time of the diagnosis, one arm on the sulfonylurea plus metformin and another arm on DPP for metformin with A1C more than or equal to 9%. Can we see when I put the patient at a 9, the A1C at the time of the diagnosis was 9 within 3 months. This is precisely after 8 weeks, A1C in everybody average has come down less than 7 in 6.84 and 6.69. And when we follow up these patients for the prolonged period of 3 months, at the end of the 30 months, that means at the end of 2.5 years, the A1C they were maintaining almost all, the average A1C were less than 7. Even Vilda group has got less than 6 even. So it is not only reduced at the beginning, but it maintained it the prolonged period of time. And we know A1C is directly related with your complication. And most importantly, for initial 12 months, it prevents the long-term complication. We have got evidence for that also. So this is evidence that if you treat a patient with A1C less than 7, we reduce the complication, and that is the evidence we have got. So treatment should be utilized in 2020. What should be the optimal treatment in our patient? It requires combination of multiple agents with complementary mechanism of action. I play a lot of emphasis on complementary mechanism. That is, pathophysiologically, it should address the maximum code effect. So multiple drug, second, should aim to achieve the best possible glycemic control with least possible side effect. That means hypoglycemia, weight gain. Should help reduce atherosclerotic cardiovascular disease in patient at high risk or pre-existing cardiovascular disease. Should help to reduce heart failure and chronic kidney disease progression. This should be our aim of the treatment. And most importantly, must start early in the natural history of type 2 diabetes if progressive beta cell failure is to be prevented. These are the 5 I will put first. It should be combination, but the combination should be early to prevent the progression of beta cell, and it should prevent the complication. Key take home message is time waste no one. That's very important. When it comes to intensification of therapy, time is the most important. Delay in intensification therapy has been associated with increased complication and higher overall health cost, and timely intensification is to communicate effectively the benefit of timely intensification and develop a shared decision making. This is most important. So Mahatma Gandhi has changed. Be the change that you wish to see in the world. Mahatma Gandhi rightly said, attitude is the little thing that makes a big thing, my dear colleagues. Winston Churchill has rightly said. So we have a lot been said and discussed about the benefit of early and timely addition of oral agent. However, its use is dismissed in the clinical practice because of your negative attitude. Friends, the time has come in the attitude and moving towards early, but I say timely use of combination therapy for early glycemic control. The most important for me, the evidence suggests is within the first year of diagnosis, as it confers the maximum benefit and least side effect, probably is the right approach to avoid preventable complication. And this is a slide I love to have, my dear colleagues. No one, the guidelines, can tell you what is the A1C target of individual patient. You and your patient who is sitting in front of you decide according to the risk characteristic what should be the glycemic target, and it is an individualized approach. And the individual approach has 3 components. One, it should not be over treatment. This has got harm. It should not be under treatment leading to chronic complication. So it should be a balance. And the balance is only when the patient sitting in front of you, you're taking into place. The key treatment consideration in 2020 is lifestyle management, individualization of the glycemic target, depend upon what individualization is the most important. Second, appropriate self-management of the glucose, metformin as a diagnosis. Consider combination therapy at diagnosis. This is the important, I will add diagnosis now. Consider it. Intensify, if not consider, intensify in time fashion. Combine therapy with complementary mechanism of action. If you have to combine with complementary mechanism of action. Atherosclerotic cardiovascular disease prevention, heart failure, and CKD. Patient-specific factors and drug-specific factor has to be considered. I think I'm going to the first question here. regarding SGLT2 inhibitor, which one do you suggest? EMPA, DEPA, Kenna? How to decide which one for whom? Dear friend Ajit Singh Pal, this is a favorite question of mine to answer. As far as if you go by the ADA guidelines for your atherosclerotic cardiovascular disease, they put EMPA and Kenna tilde. But if you go by the European guidelines, they find no difference between EMPA, DEPA, and Kenna. And when I talk to a lot of good diabetologists like Defronzos also in my personal talk, and in my personal, I don't differentiate between any. The all works and they works equally well. So it depends. Like in my institution, I have got a DAPA which is economical because of economy. This is costing me 22 rupees metformin. All the patient of mine is on DAPA, irrespective of the atherosclerotic cardiovascular diseases. It depends on the factors. So as far as personal, I don't differentiate between any. But if you go by the ADA strictly for atherosclerotic cardiovascular disease, EMPA and Kenna, and for rest, heart failure, any of the three is sufficient. And European guidelines say no difference between two, except for cardiovascular death, they put emphasis on EMPA. How much milligram of glimepiride equal to how much milligram of glycoside? Okay, it is very important, Mr. Ajit Pal Singh. So get me 4 milligram of glimepiride equal to 120 glycoside XR. This is equivalent to 4 milligram glimepiride equal to 120 glycoside XR. The maximum dose glycoside is 4 milligram. This 120 milligram XR, and maximum dose glimepiride is 4 milligram. There's a very important pre-diabetes question I am going to answer. Is the pre-diabetes has 3 components. One component is patient is only impaired fasting glucose. Second patient is who has got impaired glucose tolerance, and third patient is who has got both impaired fasting and impaired glucose. The best evidence is with the reduction in the two. The progression of the diabetes occur in 2 groups. The highest chances is who has got both impaired fasting and both impaired glucose, and second is impaired fasting. So if I have got impaired fasting and impaired glucose tolerance, I will treat the patient, and the recommendation is with the metformin as low as possible. If I have got a patient who has got only impaired glucose tolerance, and I will ask first the lifestyle modification for 3 months, 6 months, and then I go again with OGTT, and I will see not only in pre-diabetic patient, pre-diabetic patient is also a very high chance of having atherosclerotic cardiovascular disease. So I will treat the hypertension and I will treat the dyslipidemia in these patients as aggressively as in those without diabetes. Very important. My goal here will be LDL less than 70 and my hypertension will be less than 140/90. And 2 conditions. When I have got a patient who has got both impaired fasting, impaired glucose, I will treat with metformin. If I got impaired fasting and it is on the high side of impaired fasting, and patient has got family history positive, obese, sedentary life, I will definitely put the patient metformin. But impaired glucose tolerance, I can wait and watch, and I can restart him after 6 months. For me, the hypertension treatment and this lipid treatment is equally important even in pre-diabetes. Okay, what should I do? Fasting is 440, insulin is on the answer. I will even Indian guidelines and European guidelines. When fasting is more than 250 and patient has got, I have not gone, I am talking to my Himachal colleagues next time initiation of the insulin. And though the guidelines recommend GLP as the first, but in Indian setup, if patient has got severe hyperglycemia, patient has got osmotic symptom, our human insulin is considered to be best. If this patient is with me, I will convince him for the initial 2 months of pre-mixed insulin, and after 2 months, once he come down, I will put him on the OHG. And you go back my study in JAPI, where I have started the insulin in the initial 2 months, and this is a very elegant study, I think in 2018. I started the pre-mix for the initial 2 months and switch over to the OHA, followed up for the 3 years. There was excellent control for the next year. So any patient is coming to me with such a high S, I will treat them with, okay, should pre-diabetes, should start, that I have answered fasting. I have interesting question, how much milligram, okay, that I have answered. And it is best to keep sugar level higher and keep HbA1c at 8 or over. Is this correct? No. It depends upon the characteristic I given. If patient, I not even 8 and higher. The best guidelines tell you as close possible to normal as means 6.5 or less. If you go the ACE guidelines, this is 6.5. You go by the ADA, it's less than 7. But I will keep not more than 8, but I will try to keep at 8 when patient has got what you call stage 3 and stage 4 kidney disease, a lot of hypoglycemia, less life expectancy. In that stage, I will try to keep A1C near about 8, not in others. Okay. What is the drug of choice in gestational diabetes rather than metformin and insulin as percent? Mr. Priyanka Kurapata, if you ask me, my first and only answer for gestational diabetes is insulin. Okay, if you still patient is not accepting, the second is glibenclamide, by the European guidelines has been recommended. Not accepting insulin, I have to treat. I have to use. There is called glyburide. We call it glibenclamide and metformin. The two drugs approved for the in OG, not approved. And the best evidence with these two drugs, ADA does not approve it, but European guideline does approve. Does say we can use it, or NICE guideline also. Can insulin be included when the patient is already on? No. This is I'm talking tomorrow. When the patient is on basal insulin, you can use 2 OHAs in the morning particularly. You can use sulfonylurea, you can use DPP inhibitor, you can SGLT2 with your metformin. But once the patient is on a multiple dose of the insulin, please accept metformin and 2 exempt for your SGLT2 inhibitor. Don't add any other drugs, particularly sulfonylurea. Don't add sulfonylurea. Once patient is on pre-mixed BD or multi-dose of your basal bolus, only metformin is recommended. But if not controlled, we can add SGLT2 because SGLT2 has insulin-independent mechanism and to some extent DPP. But you have to reduce the dose of the insulin. Is not insulin the best for any type of diabetes? Can starting insulin not just diagnose GDM? Is not insulin? I don't say it is the best. But you go back to my JAPIs, the initiation of the insulin at the time of the diagnosis. Most of the answer I've given there, yes. The diagnosis, this initiation diabetes, I will start this insulin patient who is symptom with very high blood sugar level, particularly when the A1C is more than 9 or 10, and patient is coming immediately for initial 6 to 8 weeks. I will start insulin, and in rest I will start with the oral agent, and the guideline is in support of that only. Can we start metformin? Yes, why not? Without, okay. As far as without cardiovascular outcome trial is concerned with SGLT2, we do not have any guideline-based treatment for that. I am using it, but guideline treatment has not been established still, because the most of the trial is with your established cardiovascular disease patient, kidney disease patient, heart failure patient. So nothing is said without all these. And when we break down those who had or who do not have, though the evidence is favoring, but still guidelines has given this preference as an initial drug. You can use off, but guidelines is not in recommendation of this without having established. They do not say anything about or as initial drug of SGLT2. Till date, guideline does not support this, except it is given in the beginning when I have got a patient who has got established atherosclerotic cardiovascular disease. Now patient is coming to me, EGFR, his A1C is 9, and this EGFR is 50, he has got proteinuria. Definitely I will start with combo SGLT2. But I am coming a patient who is 9, does not have all these. I do not have any evidence to support it. So I can use of that level, but the best evidence with the support is with either metformin with sulfonylurea or with DPP-4 inhibitor. That is what I can say. How much is the cost of DPP? Yes, the DPP inhibitor cost has come down now dramatically. Now it is costing near about 15 rupees in my state because of your particularly vildagliptin, and SGLT2 inhibitor is medicine. Which one is that drug? Amrit Pharmacy. We have got Amrit Pharmacy with us, and where this DEPA and DEPA of your Risto is coming 22 rupees. So I'm writing that. And DPP Vilda has come up with your cost of your 8 rupees for 50 milligram. So it is come down now. And if I am getting DEPA with your 15 rupees, I would love to use. But still, Sita is on the high, Lina is also high, but Vilda has come down because of that is approved, that has come down, the cost has come down. The generic, it is coming in generic also. So it depends. If it's not, then before that what I was using, though it is just off the marks, don't put it in the clinical evidence. I was, because there's no difference between empagliflozin 25 and 10. No outcome trial, no difference has been shown in empiric trial between 25 milligram and 10. So what I was doing before it came in a low cost to me, I was breaking down 25 milligram into half. Okay, and how frequently is you? I use very frequently. I love to use SGLT2 inhibitor. I love to use. And can a patient be started with SGLT2 inhibitor and DP? Yes, glycemia is the drug that is a approved drug to me. Sorry to say, I have got a drug EMPA plus linagliptin, and I will share the data with some other presentation. But I am using in patient who is the patient is coming to me very high A1C and is on sulfonylurea, is on DPP inhibitor sometime, is on metformin, it on carbos, sometime on SCQ also, but A1C is 10, 11. I want to put them on insulin, they refuse, then I give them an option. I have got a drug. This is very costly, but so I have got a data of near about 49 patients. I have a data 39. I put them on the combination of EMPA plus Lina for my surprise, except for 10 patients. All the 30 patients, they responded for this combination. And they are not responding for 6 months. They are from 6 months to 2 years. And their evidence is maintained on this drug plus combination of the drugs. So yes, I've got a very good data for it, but I'm using presently this combination when patient needs insulin and they refuse. Thank you.